So I would like to welcome this second session of pediatric ophthalmology. I'm pretty sure most of our guest speakers are international speakers and we all know them. So I would like to call upon the first speaker. That is to be my close friend and my colleague who I worked in Canada with, and that is Dr. Amila. He will be taking over the first talk. Thank you. Dr. Amila, are you there?
I'm here. Can everyone hear me? Hi, Hayat.
Hi.
Hi. It's good to see you after a long time.
Pleasure is mine. Please go ahead.
Go ahead. Yes. So I'm just going to share my screen. Can everyone see my first slide?
Yes.
Yeah.
Yes.
And you can see changing as well.
Absolutely. Yes.
Perfect. Yeah. So thank you very much to the organizers of this great conference and my friend Hayat from many years ago during my fellowship days. Now, I'm going to, before I start speaking, I've got to say that I knew that when they said that, Dubai never sleeps, I really didn't think it'll apply to ophthalmology meetings as well. And I'm happy to be here, even though it's past almost close to midnight Sri Lankan time. And a hi to everyone around the world who's listening. So my talk's going to be on intermittent exotropia, evidence-based management options. And I'm a consultant ophthalmologist working in Colombo, Sri Lanka. Now, intermittent exotropia is one of the most common strabismus presentations to our clinic. There are quite a few options available to us, and this actually tells us that we don't know the exact best option as yet. So still the variation is there. Now, before we get down to managing intermittent exotropia, like we all know, refractive errors are very important that we treat. This improves sensory and then motor fusion, and this eventually gives us better control. We all know about low to moderate levels of myopia, which causes decreased accommodative convergence. So we've got to fully correct this. But you cannot forget high hyperopia or anisometropia as well, because this can cause a blurred retinal image and this impairs sensory fusion. These errors need to be corrected as well. Yeah, so now that we've corrected the refractive errors and we've got to treat the intermittent exotropia, if there's deterioration, so if it's becoming constant, if there's a decline in stereopsis, if it's symptomatic to the patient, objectives are to reduce the symptoms, reduce the frequency of the manifestation of the deviation, decreasing the angle, and eventually enhancing its control. So one thing in the options that we've got are that we could observe these children, like these two studies from 2006 and 2019 tells us, when an age range of 3 to 25-year-olds were observed, these patients were stable for at least a certain amount of time in about 55 to 60% of cases, where some improved and some worsened. So observing these patients also without actually doing anything is a viable option. And sometimes it's a bit difficult to do nowadays in a world where we always want to do something actively to treat things, but you have to keep this in mind. Prisms are not something, something historically used, not maybe any in the present time. You can use prisms to neutralize, you can relieve or overcorrect the intermittent exotropia, generally reserved for smaller deviations, but more commonly can help determine the angle, the target angle of the strabismus. That's what we use for now. O- glasses it's something that's available to us. So what this does is that it induces accommodative convergence, it promotes fusion, it decreases the angle, and this leads to a better bifoveal fixation. And this study from Wales has told us that about 45% of patients with O- glasses achieve better fusion, whereas 25% achieve better fusion actually and reduced angle. This is a good therapy. I generally use it when children are too young for orthooptic therapy. And remember not to impair vision. You can't give a over minus that actually causes significant visual impairment. There was a question about whether myopia is induced by this, and we know this paper from Dr. Bert Kushner tells us that it doesn't. So there's not a bad option to try up front. Binocular vision therapy, or orthoptics, as we say it aims to remove suppression, stimulates diplopia awareness, improves sensory fusion and fusional reserves, and restores binocular vision. This is a good option for possibly convergence insufficiency, maybe more often in adults who are more likely to follow through on treatment. And this can definitely be used as an adjunct to surgery. Now, there's simple to sophisticated binocular vision therapy, orthoptic treatment management available. Whatever is available to you is okay. Also patching, which is also, it works by an anti-suppression method. It induces diplopia and motivates motor fusion. This is an option as well. But I found that if we do this too aggressively, this can lead to post-op diplopia. Botulinum toxin, again, something that we speak about along with strabismus management nowadays, not as associated with for intermittent exotropias, but these two studies from Virginia and in the US and in Iran, it tells us that about 70% of patients in a 1 to 2 year post follow-up, a post-op follow-up tells you that the injection achieves similar results, and these patients are orthophoric just like our surgical patients. So maybe again something we could use for decompensating adults. Now, this is what are the indicators for success? So this is an important conversation to have with our parents and the family before the surgery. So we've got to tell them that, look, if the surgery is before the 7 years of age, or if it's before the XT has been there for a 5-year duration, or while it's intermittent, the prognosis is better. And that's told us by this study out of Washington. Also, what happens is you've got to tell them that if the child's got anisometropia, there's lateral incomitance, and there's immediate post-op undercorrection, then these are indicators of a poor post-surgical outcome. And also, very important, as we embark on surgery, we've got to tell the parents that about 1 in 5 patients with intermittent exotropias, they need to have a second surgery, although as many as 50% of these patients have a suboptimal either motor or sensory outcome, as this paper out of the Mayo Clinic has told us in 2009. So once you've had this conversation with the parents, now you've got to decide what deviation to correct. So a couple of ways of looking at this. So you've got this study out of Korea, tells us that after an hour of monocular occlusion, or they use the largest angle of the XT ever measured as their indicator as to how much of a deviation to correct. At the same time, you could have you could use Dr. Kushner's method of getting them to look far away, maybe a few 100 meters away, not the usual 6 meters, few 100 meters away, and then you uncover the true angle. And remember, if you're trying to do measurements at near, not to use an accommodative target. So a pen light would be a good way to measure the distance at near, to uncover the distance. Now that you know you've decided to do surgery and you know how much deviation to correct, the options available to our bilateral lateral rectus recessions versus unilateral R&R, and these studies from the PD group and from Korea tells us there's really not much of a difference in surgical success. Only recessions may be an option to avoid inducing horizontal incomitance and preventing palpebral fissure narrowing, and you also preserve muscle tissue. I use R&Rs, that's a unilateral surgery. If parents perceive very, very strongly that the deviation only to involve one eye, or if there's a unilateral ocular pathology and associated amblyopia, I would always operate on the one eye, the weak eye only. Now, once you've decided your method, and if you've got a large angle, this paper out of Korea tells us that augmented bilateral lateral rectus recessions are an option as well. Here, what you do is, in addition to what the Parkes formula has told us, you recess an additional 1.5 to 2 millimeters per eye to help control the angle. And this tells us, this study shows us that while it has lower rates of undercorrection in the augmented group, similar rates of overcorrection were seen. So this is a good option to sort of consider if you've got a larger angle that you're trying to correct. So the take home would be that, as common as this type of strabismus is, there is quite a bit unknown. And as we know in ophthalmology and medicine, when we've got something that's relatively unknown, we've got lots of treatment options available to us. So I can't underemphasize the importance of adequate refractive correction. And there's evidence to sort of tell us to try non-surgical options. You can try them. They can also be adjuncts to surgery that gives you overall better outcome. A further deterioration in the angle of the strabismus and less control becoming more constant warrants surgical intervention. And with this, I'd like to thank the organizations and thank you very much for everyone listening for your attention. Thank you. Thank you very much.
Thank you. Thank you very much, Dr. Amila. It was wonderfully kept in line with the current recommendations, and definitely we would like to have further discussion on this maybe at the end, because you are one of the panelists. We would like to hear and have our discussion, especially with Professor Michael Graff and others. So I would like to now take the opportunity, as my colleague, Dr. Sisma is not there, I would like to take my presentation next. So I work at Mediclinic Parkview Hospital as a consultant ophthalmologist, and I would like to thank Qasimi Ophthalmology International Conference organizer for giving me an opportunity to organize the pediatric sessions and thankfully giving this interesting case presentation. So, let me just share my screen. We're all set. So I don't have any financial disclosures for this talk, and let me just talk about this kid, a 4-year-old healthy girl who came with a trauma in the left infranasal periorbital area, which is sustained while playing in a garden and when she ran into a tree, and was brought through the emergency department after doing a CT scan. And of course, they were referred to the eye clinic after having the CT scan done and having a laceration of the skin. The patient had the history of diplopia with increased swelling of the eyelids and with the left eye redness in the periorbital area and the painful eye movement. Patient was irritable, uncooperative on examination. There was proptosis associated with motility restriction, chemosis of eyelids, of the left eyelid, and of course, visual acuity was difficult to evaluate, but thankfully the pupil was round regular and normally reacting. So this is how the patient came in. As you can see, the laceration. And if you go from the right to the top under GA, we have taken this picture, and if you notice this, that there is a clear proptosis of the left eye. On reviewing the CT scan images, as you can notice here, you can clearly see two distinct features. One is there is a clear proptosis of the left eyeball, as well as there is a hollow shadow that you can see in between the medial rectus and the ethmoidal sinus. So the medial wall in between, there is something suspicious. And of course, reviewing the axial length, if you see carefully, this is a hollow shadow that you can see going right throughout from the, is it emphysema, is it air, was it, what is going on? So that was the question. So there again, if you see, this was the question. And then going on to the coronal section, again, you can see, but I just go back a little, if you see, there is a solid area that you can see here, which was quite distinct on the coronal sections. And then going on to the sagittal sections, you could clearly see there is a foreign body. So that was it. So a decision was made promptly to take the patient for under GA, taking in for an examination. And as we explore right away, you can see there's the wooden piece. So as it was explored, as you see, it's coming out. And it measured about 3 centimeters. Important to also see there are a lot of grayish, blackish, you can see all the dirt around it. So basic resin with BSS was well irrigated into the abscess area, which was formed in a short span of time. And once it was done, a clear, you can see the anterior and posterior segment examination was conducted. And finally, Of course, a drainage tube was also put in with a 5-0 silk to be held on, and as you can see, it's very clearly distinctive here. And in the literature also, we found something similar size and shape that you see. It is quite distinct that these can have a very small area of entry and a large piece of wood can be there. So pressure, intraocular pressure, which was 32, which would have thought at one time to do a lateral canthotomy, but rather than that, the foreign body was removed. And once it was removed, drainage pipe was put in after retrobulbar irrigation. And then, of course, drainage tube was inserted and the IOP came down to 18 millimeter mercury. Later on, vancomycin, ceftriaxone, metronidazole was then given in for a week of admission, IV, and then which was followed by oral ciprofloxacin for another 1 week. The patient, for the whole first week, had an adduction left eye deficit, which was improving but was still there. Visual acuity was both eyes equal. The drainage tube was removed the very next day, and then Steri-Strip was used to close the wound. At 1 week, tobramycin ointment was applied, and 1 month follow-up, a good healing was done. 8-day follow-up, as you see here, very clearly distinct. There is an adduction deficit. And then 1 month later, a dramatic improvement, full visual recovery, as well as the extraocular movements were normal, as you can see there. Important was the bacteriological report, which showed, especially from the deep orbital swab, some strange organisms that you see there. The question was then whether these organisms are, what were they doing? And you would be, of course, we all should be knowing that this is quite often you will find these organisms. You can find some of the most unusual organisms in these cases where you have a lot of debris. Now, radiologically, the most important topic that we would like to take up, especially for wooden foreign bodies. So any time there is a vegetative material, of course, plain X-rays are not that helpful. A B scan or an ultrasound can be helpful, but has limitation in terms of orbit being larger, and pictures may not be well enough to differentiate, especially if wooden piece has air around it. And there is a lot of literature showing the same, that even CT scan sometimes is important, but can be sometimes difficult if we would like to see, and it's better to have a clear understanding to differentiate foreign body, which may look like air on a standard CT scan window setting. In that case, a white bone window setting would be helpful to distinguish the wood. And how it will be? It will show the reticulated matrix of the wood, and that will be easy to differentiate from simply a gas collection. So, but then still, sometimes it can be difficult. And then the best thing was, once we rule out there is any metallic foreign body, then we can go ahead and go for an MRI, which is quite helpful in making a final decision and a prompt overall decision as how to go about. So in the literature, we have a lot of publications talking about whether we should take them out, whether sometimes they have to wait, sometimes they're very deep, or if they are metallic or something which is inert, you can keep it, but otherwise you have to take out. There is definitely sometimes the wooden foreign bodies are unrecognized in the orbit, and it's very important and prudent that we do a good workup of these patients and remove them as early as possible for problems like abscess formation, and then of course later on bigger issues which have been reported in. Also, it's important that every case has to be individualized, and a management has to be individualized. So a good history taking, an assessment of the injury, good imaging, wherever once we have excluded MRI and any evidence where we feel that there may be an organic foreign body, it would be better to do an MRI. Always don't forget to give an anti-tetanus prophylaxis and broad spectrum antibiotic. And if it is an organic foreign body, it has to be surgically removed. If it is organic, still there is a surgical removal needed. if it is having a persistent inflammation, and of course, especially if it is a copper foreign body, it has to be removed. If it is inert, it can be conservatively managed. And important that we need to also try to have another MRI done if we have any suspicion that there may be a retained foreign body. So the take-home message is, of course, we have to see and make sure that early signs and symptoms are easily measured, and displacement of globe, persistence of any inflammation, and extraocular movement displacement. Where you see that there is restriction, it is always important to look up these cases. Always remember, wood density is similar to air and fat. So a well investigation and MRI is, of course, indispensable, especially in organic intraocular foreign bodies. Thank you very much. So I would now call upon my esteemed colleague, Professor Michael Grave, to take on the stage and present his next presentation about lateral rectus nasal transpositions.
And at first, I want to thank Dr. Khan and Dr. Alamri for inviting me. I'm very pleased and honored to participate in this conference. My talk comprises 3 decades of lateral rectus nasal transposition. This is nearly exclusively performed for third nerve palsy. So at first, one slide on timing and indication of surgery for operatic strabismus. We do not operate earlier than 12 months after the onset of the palsy if improvement of the palsy is still possible. For slight or moderate palsy, recess and resect surgery will suffice. For paralysis, and this is roughly when the eye does not reach the primary position, transposition surgery is sensible. This figure shall illustrate the first lateral rectus nasal transposition as reported by Taylor in 1989. He undercrossed the superior rectus, cut the superior oblique tendon, and fixed the lateral rectus at the nasal superior sclera. In this schema, with a linear representation of the anterior-posterior direction on the surface of the eye, the frontal plane or coronal plane, respectively, becomes increasingly stretched behind the equator, following a reciprocal sinus function. The posterior pulsar becomes blown up to a circle near the outer circle here. Superior nasal transposition has an adducting, elevating, and excyclorotating effect. For comparison, inferior nasal transposition acts adducting, incyclorotating, and depressing. This patient with a right nuclear palsy was 30 degrees exo and more than 25 degrees hypertropic. His encyclotropia will increase by nasal inferior transposition, of course, but fortunately he excluded the image of the paretic eye. So we performed the inferior transposition, considering that we could complete it to a brittle operation if needed. I'll explain that later. The result was a full horizontal correction and the desired over effect in vertical position to allow for slight down gaze. Due to suppression, encyclotropia was no problem in this case. This 14-year-old girl suffered from traumatic third nerve palsy. Her right eye was more than 30 degrees exo and 20 degree hypotropic. Motility of the left eye was normal. To avoid excyclotorsion, we combined superior nasal transposition of the lateral rectus with a Harada-Ito procedure. This means we disinserted the superior oblique tendon, transposed the lateral rectus, and finally fixed the superior oblique tendon at the superior edge of the previous lateral rectus insertion site. That was the result 1 day after surgery. The eye position was fine. Nevertheless, the patient was not able to use her binocular vision. We continued contact lens occlusion, which she had required already before surgery. For aesthetic reasons, she now used an additional ptosis clip mounted at the frame of her glasses, as you can see here. This is an older model of ptosis clip. We prefer that for patients with myasthenia or CPEO. The girl just shown wishes ptosis surgery, of course, which is not quite riskless in this situation. The so-called bridle operation is a combined superior and lateral rectus transposition to the nasal inferior sclera, which is more effective than Knapp's procedure that ended at the insertions of the paretic medial and inferior rectus muscles. It creates a temporal upward directed force vector at the posterior sclera that turns the eye nasal downwards without cyclorotation because the in and ex cyclorotating forces neutralize each other. This nicely shows the effect of transpositions is nearly exclusively induced by the distal part of the muscle inside Tenon's capsule, as depicted down here, while the proximal part largely keeps its original direction. The decisive forces act between the pulleys and the new insertions. This patient who received a bridle operation was also happy with his new eye position, but he also preferred to cover the eye most of the time. This demonstrates the fundamental limitations of lateral rectus transposition surgery. It improves the eye position, but of course not the motility. Diplopia remains, or even maybe more disturbing because of the moving double image. And this is mandatory to inform patients about that. Lateral rectus split nasal transposition is the most often performed method for complete third nerve palsy. It has no vertical effect and avoids cycloduction. Herbert Kaufmann described it 30 years ago. Myectomy or complete tenotomy of the inferior oblique muscle makes surgery easier and faster. However, we always preserve the superior oblique that can be useful for augmentation or cyclorotation, as we have just seen. More anterior or posterior anchorage of the lateral rectus, as symbolized by the arrows, is a current point of discussion. This is an example of bilateral complete third nerve paralysis. Only the lateral rectus muscle was functional. The figures on top in right and left gaze show the lacking adduction. Below the finding after bilateral splitting and ptosis surgery, diplopia was tolerable for this patient because both eyes did not move. He even achieved some stereo vision. This graph shows results of 65 splittings in our department, arranged by the magnitude of the postoperative angle of strabismus. The graph includes bilateral palsies. That explains part of the residual exotropia after the first surgery at the left-hand side. The cases at the right end of the distribution show that even overcorrection is possible. We do not only estimate residual squint angles, we measure them exactly. Here is a slide on subjective squint angle measurement by the diplopia and confusion method at the tangent scale. The last example, this patient with a bilateral third nerve palsy and highly complex motility disorder first received a recess and resect surgery on the left eye, and then in a second procedure, split lateral rectus nasal transposition on the right eye. He was happy with the result, and also he needed still occlusion. So what have we learned about lateral rectus nasal transposition within the last 30 years? Lateral rectus nasal transposition provides strong effects, stable long-term results. It restores normal physiognomy and can correct the head posture. And in most cases, it does not superfluous the need for occlusion. Thank you for your attention.
Thank you. Thank you so much, Professor Grafe. I would like to ask one question that is these third nerve palsies. I have seen especially like how long do you wait usually for the adult cases, acute cases that you see, what is the immediate, of course, we try to give them some patching, but what is your take when they come to your clinic, let's say within days or weeks?
We first wait. If improvement is possible, wait 1 year, because most of these procedures are hardly reversible. And for this time, occlusion, if needed, is recommendable. And we tell patients, diplopia, the images are far from each other. They will come closer, but you probably will not possible to see one image, even in the museum. Even if you do not move your head, you will still have diplopia and probably will need further occlusion. You can open your eyes for special situations, if you like, for aesthetic reasons, but for everyday life, most patients prefer occlusion if they are not possible to suppress.
Yes, especially I have had problems with they are using tapes to keep the eye open. For the ptosis, what is the usual thing that you give for? Sometimes it's very disability, especially if you have bilateral cases.
I think the most harmless way is this ptosis clip mounted at the glasses, but not every patient likes it. Yeah. It is harmless. And the surgical method is not quite unrisky, because you can make an, usually the levator muscle is paralytic. You can do a frontalis suspension, but Bell's phenomenon does not work. The eye does not move, and so the risks of corneal ulceration or corneal lesions should not be underestimated.
Absolutely. Dr. Amila, do you want to add something on this? How are you dealing with these cases?
Yeah, I think the key thing was there in, waiting and seeing how much we can improve in that. I would say definitely 6 months, nothing, but at least an year with all our other supportive treatment. And then also when undertaking this sort of like Professor Graf said, it's not only irreversible, but it's very unpredictable as to how the outcomes can be. So I think everyone involved, especially the parents, they really need to be kept in conversation where, we're trying our best to get this corrected, but the outcomes are really far from predictable. Improvement definitely, but how much, difficult to say. Great presentation, Prof. Enjoyed it.
Sorry, I just repeat, I didn't realize. I'll just repeat that I would like to just switch gears and come to the important topic and the more common topic of exotropias, intermittent exotropias. And I would like to ask Dr. Graf about his experiences and what would be the pulse he would like to share.
Excuse me, I did not understand your question. The last sentence of your question, please.
Intermittent exotropia and the management.
We prefer recess and resect, or better, recess and placate surgery on one eye. And the recurrence is not a new thing. Many patients need a second surgery, more or less later, which can be performed on the second eye. Then we have symmetric conditions again. And the diplopia in side gaze is less a problem in the intermittent exotrops. We differentiate between the intermittent exotropia, who can switch between corresponding normal corresponding retinal corresponding vision and correspondence-less binocular vision, as they do before surgery. When they are exotropic, they don't have diplopia. So the diplopia in side gaze is less a problem in these patients and more problematic in the patients with exophoria, who can only do normal correspondence and not perform this correspondenceless binocular vision.
Okay.
Would you agree with this?
I completely, I always try to, I have never had a particular preference of the reset resect as compared to bilateral symmetrical surgeries. But I do not have a cohort with the 30 years of follow-up, but the follow-ups that I have practically almost similar results with both the procedures. Amila, would you like to add? Do you only do reset resects or
no,
bilateral?
Yeah, again, it depends. There's so many variations. I think I would say that, you know, R&R on one eye would be good, because then you can actually keep that eye closed overnight, the one eye that was operated on. Parents also generally happy with R&Rs because you're just operating on one eye. And sometimes when they see the squint only in one eye, I mean, the question is as to why you're operating both eyes. But again, you've got to sort of take it. There is no one rule that fits everything. You've got to take it per case, have all the options open, and then, like I said, you know, have the evidence to back whatever decision you take. And then generally with this, you know, most parents understand, and the outcomes are still unpredictable, but they're as closer to prediction as you can bring it about.
Thank you, Amila. So now I'll take Dr. Sismar's permission and request Dr. Kamir if he would like to start his presentation, and then maybe Dr. Burke can have in the end the last. Would you give us a permission, Doctor? Yeah, go ahead, please.
I can't share my screen, Hayat, until, oh, perfect. Okay. Hello, everybody. Great to see some familiar faces from the past. Hayat and Amila. We miss you guys in Toronto. And it's great to see you guys doing such great work. And I'm just going to start everything here. And thanks for the invite to be speaking at this great session. So my talk is really about a nystagmus surgery and for abnormal head posture, and you know how to get that sweet spot. I just want to share a case and a simple management algorithm that really is helpful if people want to use that. This is an 8-year-old girl who had a horizontal pendulum nystagmus since birth, has been investigated for any causes. Initially, they thought it was oculocutaneous albinism, but didn't really meet all the criteria. Her vision is not too bad, and for near, she has no head posture, but for distance, as you can see in the picture, she does have a significant right head turn, a bit of a tilt, and a chin up. And before coming here, she had tried prisms to just kind of move that gaze, and really only tolerated a small amount of prism. So here she is. I'm going to run a video for you guys. Just read those letters.
H, B, C, D, S, N, C, B, K, D, C.
Just read those letters.
H, B, C, D, S, N, C, B, K, D, C.
So as you can see here, sorry, I just go back, that with the you gotta go right to the top again, and it looks a bit more straight.
H, B, C,
but then as soon as she starts having to read, then the eye turns over, the head turns over a little bit more. Okay, that's really good. So this is sort of how she has been managing, and she's a very bright girl. And for near, again, I won't necessarily run you through the whole video, but you can keep her head straight. But what's interesting is that in the same way as you saw with distance vision, when she reads with the glasses, her tilt increases a little bit.
Of course I'm sure, said, laughing. Wait a minute, standing right in front of them. Can you touch my hand with your nose?
So far in summary, we're seeing a girl who's got fairly good vision. She has no head posture when she's using her convergence to dampen the nystagmus. And for distance, she has about 18 to 20 degrees of head turn, although it does look more than that. And she's helped a little bit by just wearing prisms in front of her eyes, but she's really not tolerating that well. And we came to discuss surgery. Now, there are many options here, and what we're all familiar with is the Kestenbaum procedure, where you look up at the table and then you decide on the degree of head turn, and you have a table where you can sort of look up and do your recess resects for this. I just want to go through a different approach to this, which many may be quite familiar with, and basically just to use a prism to figure out how much you want to operate on.
H, B, C.
So again, this is a way of just saying what the eye wants to tolerate and what it takes in terms of thinking about the eyes as this eye has an esotropia and the other eye has an exotropia. So you can use different prisms to decide, how you can straighten the head.
C, D, S, N, C.
Yeah, Karen.
B, K, D, C, C, S, H, N.
All right, go back to the top and start reading again.
H, B, C.
And again, here you can see that the right eye is driving the head posture. And her vision is not too different between the two eyes, but basically the right eye is the eye you really want to get. And again, this video shows that for near, you use the prism and it doesn't alter her head posture. So you're not messing up her straight eyes and head in the primary position.
Yeah.
So this is a very, if you like, a practical way of testing what your potential surgery is going to do and what it takes. So here with 20 diopters, there was really still a little bit of head posture left, but with 25, she could have a straight head, even turning into the distance and reading fine print. And for near, it didn't really mess anything up. So, and also it tells us that the right eye is driving the head posture. And in theory, if you do 25 diopters of surgery, which means treating 25 diopters of esotropia in the right eye and 25 diopters of exotropia in the left eye, then you should achieve what you need to. So this is for my table, this is what I would do for the 25 diopters that we discussed. And here, again, for medial rectus recession, you're seeing 4 millimeter, whereas your classic, let's say we had 20 degrees of head turn, 5 millimeters. And I found that, I'm doing less surgery than that's suggested by the table. But again, maybe you could argue that the 30 diopters, prism diopters was maybe even better. But the point is that the classic tables are based on degrees of head turn. And again, that's unless you have the protractors, which we do have, it's hard to measure the angle accurately. But I found that with this, I was doing less surgery than was suggested. And this is her pre-op. And just 6 weeks after the surgery, her eyes, her head was quite straight. And you can see that she's still red where we've done some surgery. And again, when she starts reading, there's a bit of a head posture coming back in. This is just 8 prism diopters then corrected that. But she felt better and she looked better. And with time, her head posture just kept coming up. And with 8 diopters, prism diopters, she was better. So you could say that, well, actually the Kestenbaum would have given me more numbers and that would have corrected it. And what's interesting is
I don't know why I was looking.
She seems to be doing quite well. And then when you do follow her up post 2 years, the classic thinking is that the head posture has a tendency to come back. And against that is the muscle memory that they just like turning their heads because that's what they're used to. So in 2 years' time, her vision had improved more. And her null position, unfortunately, I don't have the video, was actually quite straight on, even reading down the chart. So just that little tilt as she had before, but there was no other issues. And so we continue to monitor her on a yearly follow-up, but her head has actually been quite straight. And we did a little bit less surgery than maybe would have been suggested by the Kestenbaum. So just wanted to bring up this technique, which is a good way of assessing which eye is driving the head posture. And, you know, in practical terms of you do this much strabismus surgery, and you could see what would straighten the head. And I find this very helpful for the eyes that have head posture and a strabismus. So you can use the prism that it takes in front of the good eye to straighten the head, and then you can do a cover test over that to see how much to do on the other eye, and it just makes it easier to calculate then and in angles. And again, makes the average strabismus surgeon think in terms of I'm doing this amount of esotropia surgery and this amount of exotropia surgery to correct the thing. It's just another easy technique to have in your armamentarium. And this is for nostalgia for both Hyatt and Amila. Toronto is still beautiful, and we look forward to welcoming a lot of people in the future when travel is a lot more allowed. Thank you very much. I hope you heard all that okay.
Thank you so much. It's always a pleasure, and it's so much interesting information Dr. Kamir shared. Definitely, it's wonderful, this technique. So we will have a discussion about this. Maybe if Dr. Kamir can just wait for a while, we'll have Dr. Gorka he can just please go ahead and take his presentation, please. Thank you.
Thank you, Hyatt, and sorry for the late arrival. Technical issues put me in difficulties. Let me see. Can you? Sorry again, and thank you very much for the invitation to this nice and important forum. Thanks all the panelists, all the speakers. Well, today I'm going to speak about this interesting case about the ocular nerve palsy with aberrant regeneration. Ocular palsy with aberrant regeneration is called also, or is called ocular synkinesis. And as we can see here, is running or running. Okay, we present a case of a patient that comes to us with a right third nerve palsy, and when the patient moved to abduction, the eyelid goes up. I don't know what is happening that is not running, but in this case, we see patients that when they have abductions, they can have elevation of the eyelid, pretending or simulating a ptosis when it's not a real ptosis, it's a pseudotosis. So this could be primary or secondary. There are the causes that we face here, primary or secondary. And in this case of the primaries, probably the most common cause is secondary to injury, and sometimes and many times associated to trauma. So we see these patients often in the clinic. Let's see this case. This is a kid with a 12 years old, here of motor vehicle accident a year ago, presented to the clinic with eyelid ptosis, hypertropia, exotropia. The patient was operated at the age of 3 years. They did this procedure, lateral rectus recession plus resection, and this is the patient in the pre-op HOPS. You can see how when the patient has abduction, the eyelid goes up. How when coming inductions, the eyelid goes down. So based on these findings, this is the vision, poor vision in the right eye, ptosis in the right, pupil affected, and this is the deviation of primary gaze, esotropia of 10% diopters with the right hypertropia, huge hypertropia, but the main complaint of the patient was the ptosis. So the patient came to our clinic, so we decided to do surgery for this. So because the patient has already 2 muscles separated before, the main complaining was the ptosis, but the patient also has a hypertropia based in the hearing slow and based in the concept of primary secondary deviation. We decided to do surgery. So the question is, can we become an oculoplastic surgeon being pediatric ophthalmologist? Well, the answer is yes. Based on that, we use prism. This view doesn't want to run. We use a prism in front of the patient, and we measure for example, in the healthy eye, the amount of opening the eyelid when we place the prism with the base in. This is going to be the number of the surgery that we can do. Of course, if the deviation is higher than 50% diopters, probably the patient is going to have residual ptosis. But this is the case of this patient. We decide and we proceed with the surgery. So the concept that I want to make you understand for the general audience about this is because we place a prism base in to induce XT, so we need to treat these patients, we need to treat and induce an isotropia in these patients. And we need to base in the, probably independent which is the fixating eye, but in this case, we are gonna induce an ET in the healthy eye, in the left eye, and we decide to do a left lateral rectus resection of 10 millimeters and left medial rectus resection of 7.5 millimeters. This was the procedure. And this is the post-op. The patient, I don't know what's happening today with the videos, but they don't want to run. Unfortunately, let me see if I can. Well, and that's not went wrong. Well, the response to this is that the patient, when fixed with the left eye, immediately the eyelid ptosis disappear. So the concept of this surgery, the purpose of this surgery is that we can treat the pseudotosis, calling like this, when we face patients with aberrant regeneration, and we can use the healthy eye to do this. This is a couple of papers that you can have here. You have the QR code, you can download it, you can read further if you are interested to do this. This is the idea of this procedure and can help us to treat patients with aberrant regeneration. Thank you very much.
Yeah, it's time to have a discussion then.
Let me, I don't know if I have time later because the video was not running, but go ahead.
Yeah. Dr. Kamir, would you like to make any comments? Dr. Kamir is there.
Hi, that's very interesting. I haven't tried that, but another use for the prisms. I wonder, your patient population, how is their tolerance for surgery on the good eye in these situations? Because our patients get very scared.
This is a very, very nice question, an interesting question. And usually, personally, I try to refuse to do surgery in these cases based in the ethical or in the risk of the procedure. You are absolutely right. I try to avoid these surgeries, but the patient came almost begging for the surgery, and after explaining widely and expressively and clearly about the risk to do surgery in a healthy eye, he says, doctor, my cosmesis is important. No, I'm suffering. Based on that, we took this decision. It's not common. We don't do it. We have, until the moment, I can tell you that we have 4 cases performed doing these cases. Fortunately, are not the most common, and how's the third nerve palsy, that is probably the mission impossible cases that we all as surgeons we face. I avoided, but the patient, I'm not a fan of these procedures. I did it because the patient push, and after explaining, well, I decided.
I think you bring up a very good point in that these are really desperate patients, and you're right. It's not that strabismus is a very high risk surgery. If you quote the highest, 1 in 3,000 risk of damaging vision in your good eye, it's not the highest risk, but some people are very desperate. And in a young person, they've been told probably by 10 people that there's nothing you can do. You cannot undo aberrant regeneration. You cannot do ptosis surgery because then you get exposure and you get ulcers. So they've probably had so many rejections that they're very desperate. So I think this is a good option for those that, as you say, are desperate to have it done. It's sorry we couldn't see the video. I would have liked to see how he looked afterwards. Yeah,
you can keep discussing the receipt. I don't know. We will have time. And sorry for this unpleasant thing. But it's interesting the result that we have. Then this is running. I don't know if the other people have other questions that can.
No, definitely, especially looking at the bold numbers that you did for the resection and the recession, that was something, especially on a normal eye. I don't know. I was really wondering that has to be really bold, and you have to be knowing what you're doing and what you're expecting.
For example, fortunately for the most of the people, the third nerve, most of the time and most of the problems are solved with R&R, I mean, resection procedures, fortunately. Not like the cases that we face that we need to transposition the lateral splitting or moving the superior or doing magical tricks to do nothing. No, sometimes because it's a challenge, you know. But in these specific cases, I see interesting, no, like well, the patient almost begged and pushed, and because of that, I decide to do it. Especially if you see the patient has a huge hypo, no? But I can do more surgeries there. The patient is already operated twice, so the risk of anterior segment ischemia is there.
Professor Mike, Professor Mike, Professor Michael, please.
Thank you. I think you needn't excuse for operating on the better eye. Correctly performed recess and resect surgery is really harmless. I think the effect of surgery should be simulated for a longer time with prism foils. Is the effect as desired? And does surgery cause an abnormal head posture? If not, okay, then it's really a harmless kind of surgery. An alternative would have been, if you want to operate only on one muscle, you could recess the lateral rectus muscle, in this case, on the left eye, by a very big amount. So if you're afraid of anterior segment ischemia, I would not be afraid in case of horizontal recess and plicate surgery. But if you are, then you can preserve the vessels of the medial rectus. But there are only to my experience, there are only very few patients who can be treated in this way. Mostly the misdirection is not strong enough, no? But this is a very interesting case you showed.
I don't know what happened with the video. Was sabotage, you know, was moving before, and now I was looking for the. But it's
yeah,
you can trust me, that works.
Just I wanted to ask if anybody would like to make any comments on Dr. Kami's presentation, where he had presented beautifully presented the videos, how we can use Prism to, yeah, please.
One question. No, in this case, the patient that you presented, the patient was basically ortho primary gaze. What is the formula that you use in case that the patient is coming with an anomalous head posture? You use your table. I mean, I like your numbers, no? But how can you add? Let's suppose that the patient comes with XT of 20 or 25. How can you? This question is for the audience. I mean, for you, doctor, but to teach and educate the audience about how can you adapt extra deviation a patient who has a anomalous head posture?
So that's a very good question. So what I do is, once I know which eye is driving the head posture, then you will use the prism to keep the head straight. And then on top of that, you do a cover test to see how much strabismus you have, which is usually in the other eye. And then if it's 20 diopters of whatever it is, then you will take that into account when you are doing your surgery. So in a situation like this, you would say, well, it takes 25 diopters of ETXD to get the head straight. And then on top of this, I need another 20 diopters of XD surgery. So then you make the other eye a 45 diopter XD that you're operating on.
And sometimes you don't. For example, if you need to do a medial rectus recession of any in your original plan, and the patient has CT, so you need to do, and you go for this muscle and you reduce the number in this muscle, or you go to the other eye. I mean, you instead of doing 4 or 6, you okay. Let me reduce here.
Yeah, I would do a direct additional whatever. So if the eye's already ET, then and you need to make an ET movement of the eye, you just do less of it. Because it's usually what's important is knowing which eye is driving the head posture. So if their problem, they come to you saying that I hate that my head is like this, then the primary thing is what gets the head straight. And then once you know that, then you can measure what it takes on the other side to get it that further on. So you figure out what gets them straight. And then on top of that, you need to do less surgery on the other eye or more surgery on the other eye based on like direct addition of the prism diopters, if you like. I don't know if I'm making that clear.
You add FAD to the procedure or not?
No, but that's a very good point. I haven't done it, but it's a possibility.
I think with this small dosage of surgery, when you do artificial divergence surgery, with such small doses, you can correct for large head posture if convergence innervation dampens the nystagmus. But if it is a nystagmus that is just dampened by side gaze innervation, we need a much larger dosage, as you showed in your presentation. The augmented Kestenbaum and Park's modification of Kestenbaum surgery. And you can augment and augment. It will never be enough, so we switched to high-dose Anderson surgery. And with this small dosages, it is possible to correct for head posture and to increase the null zone if convergence innervation dampens the nystagmus. And this, in our patients, this is a small percentage only. Sometimes we do asymmetric Kestenbaum surgery, and then, as you told, surgery on the non-strabismic eye corrects for the head posture, and sensory on the strabismic eye has to be adapted on the calculated effect of surgery on the other eye and the remaining squint angle.
I always found that doing Kestenbaums is, 40% augmentation, it just gets a little bit tricky. Whereas this way you can show the parents, this is what we're doing. This eye is turning the head. This is what we need to fix. And this is, it just, they understand it better, and it's easier for me to calculate, especially if you have to then build in an easy ET or XT into it. And then again, at large numbers, you're right. It just, there's so much you can push the muscles anyway.
Just one comment, because you said it is difficult to measure the head posture exactly. It is difficult to measure the vertical head posture, because what is vertical, right? It is easy to measure tilt, and it is recommendable to measure the head turn in this way. You can go 5 meters away so that the patient has distant vision, not near vision. And if you see both ears, as I see you, when both ears are visible, then the head is straight. The nose is mostly weak, no? And it is, of course, very important to measure postoperatively as exact as preoperatively.
Yeah, exactly.
There is a question for Dr. Amela. If he can answer, go ahead, Dr. Amela.
Yeah, we're just actually typing in the answer. So the question was, what would be the oldest age, I think I understood, to be when you would operate an exotropia? So there's no real age limit. Again, depends on what the patient wants. And in pre-op measurements, if there is no diplopia up to a certain angle, I would correct that total angle.
Anybody would like to add anything? Of course, Dr. Sisma is supposed to moderating now. He's there. So anyway, it was a wonderful session, and I'm pretty sure the organization has given us this last slot so we can talk as much as we want. So anybody would like to add on anything, please go ahead, so that after that we can just conclude the session.
Yeah,
I think just from my side, I've learned a lot, and thank you for the session.
Yes, I want to thank you too. Thank you very much.
Always a pleasure. Always a pleasure. And of course, Kamir has always been so supportive of academia. I remember even from the days that he was in Canada and here internationally. It's an amazing job. And this meeting has been very cosmopolitan. We have people from Sri Lanka, Germany, Saudi Arabia, Dubai, and of course Canada. So it was an honor to be with all you esteemed colleagues. Thank you so much for being with us, and we hope to have more sessions like this. And thank you once again, everybody, and have a great day ahead for Kamir, and good night for others.
All right. Good night. Take care.
Thank you. Thank you, everyone.
Thank you all. Thank you all.
Thank you.
Thank you all.
Thank you. Thank you.